all useful at treating nausea and vomiting. They are neuroleptics. So a patient who has Parkinsonism, those medicines are absolutely forbidden. Okay, now getting back to Lewy body disease. Again, McKeith and colleagues at Newcastle in northern England, I think, deserve a real, accolades for putting, as I said, DLB on the map. And back in the mid-1990s, they had established guidelines for the diagnosis of DLB, and essentially, these are the same today. Obviously, dementia is a mandatory diagnostic criterion. Core features include, so not only the thinking fluctuations, but behavioral fluctuations. Parkinsonism, visual hallucinations, also RBD, which is REM sleep behavior disorder, which I'll go into more detail in a moment. Very typically, patients with Lewy body disease will often have, or typically have difficulty with syncope, which is fainting. They have this because the parts of their nervous system that control regulating blood pressure, those nerve cells also begin to fail. When we go from either lying flat or sitting to standing up, because of the force of gravity, our blood pressure drops. And normally, it's trivial how much it drops, and normally the nerves that control blood pressure, respond instantaneously, make sure the blood pressure stays adequate to pump blood north to the brain. But if you've ever, I'm sure all of us have experienced, particularly here in South Florida, if we're dehydrated, that sometime you may get up and all of a sudden kind of feel a, weird sensation like, you could pass out or you just don't feel right. That's what we call orthostatic hypotension. Okay, if it's severe enough, it leads to frank fainting. This is a very serious problem in most patients with Lewy body disease, but again, very treatable, as I'll mention in a moment. Again, repeated falling is very common. The loss of consciousness for periods of time, I actually put this in with the fluctuations. Patients with Lewy body disease, as I said, at times I've had families call me and say, "Oh my gosh, my dad's dying," where he's been hard to arouse. So that's very typical, and I'll get more into that momentarily. Paranoid delusions. When you may hear the term psychosis used, somebody's psychotic. Well, Dr. Stewart may correct me on this, but as a neurologist, the way I think of psychosis is, that it's an illusion of either a sensory perception, so what we see, what we hear, what we smell, what we taste, or an illusion or an impairment in thinking. So a delusion, believing the CIA is bugging your telephone, or that people are trying to break into your house. These sort of paranoid delusions are very common in Lewy body disease and also are a component of what we term psychosis. Again, a patient who has gotten one of those neuroleptics that I mentioned and had severe reaction to it. What is severe reaction? Developing severe muscle rigidity and bradykinesia. Okay, so Parkinsonism. That is, a patient who comes into the hospital and is having behavioral problems, and the resident on call is called and gives the person a dose of Haldol, and that person then becomes rigid as a board. That's what I'm talking about. It's very, very suggestive of Lewy body disease. Again, visual hallucinations and now, I think Carol had mentioned that she has a handout from my friend and colleague Brad Bove. I just want to say, that Brad Bove deserves a lot of credit for his groundbreaking work in dementia, and particularly with REM sleep behavior disorder. I think that this insight has provided a great deal of assistance in our abilities to recognize different forms of dementia and other neurodegenerative disorders. You'll recall that when we sleep, we have different stages of sleep, from light sleep to deep sleep. Deep sleep is what we call REM sleep, or rapid eye movement sleep. it is in REM sleep that we dream. Now, essentially the brain has a thermostat such that while we're in REM sleep dreaming, the muscles of the body are paralyzed, except for the eye muscles and the diaphragm, of course, so you continue to breathe and don't suffocate. But this is a protective mechanism, and the reason is that if, let's say you're dreaming, you have a vivid nightmare that you're being tortured or beaten by Al-Qaeda or something, and you're trying to resist that in your dream, if you can act that out, it can be dangerous for yourself and for your bed partner. So the brain, again, has this thermostat where it basically paralyzes the muscles during REM sleep. In a variety of neurological disorders, particularly dementia with Lewy bodies, that thermostat doesn't work properly. And so REM sleep behavior disorder is, and I see people nodding their heads, so they recognize this with family members or whatever, that during vivid dreaming, that patients with these disorders, that their muscles are not shut down and they're able to literally act out the dream. So I think, as I said, Brad Bove deserves a ton of credit for making that connection. What we have learned is that disorder, RBD, is extremely sensitive and specific for disorders that are associated with abnormal aggregation of alpha-synuclein. We call the synucleinopathies, including Parkinson's disease, dementia with Lewy bodies, and MSA. You'll recall I showed you the gentleman a moment ago with Parkinson's who has MSA. All three of these disorders are involved with abnormal alpha-synuclein deposition, and so when a person has RBD, the chances that they have one of those three disorders, I'd say, is 95+% at least. The good news is that condition, or this condition, is extremely responsive to clonazepam, a medicine that's a cousin of Valium. So this is one of the real success stories, actually, in treating these disorders, that this is one problem which is monumental, or it can be, that we typically really can treat effectively. Okay, so that leads me into segue into treating complications of DLB. So the dementia, the problems with cognition, with memory, and other spheres. The medicines that help to promote the transmission of acetylcholine being another neurotransmitter like dopamine, but very important in areas of the brain that are related to functions such as memory and other cognitive functions. These disorders, the donepezil is Aricept, and then there's some others. These medicines are useful, and clearly not only in Alzheimer's disease, but in DLB. I mentioned the RBD a second ago. Psychosis, again, I'll be interested what Dr. Stewart's take on this is. But psychosis, so again, the hallucinations and the delusions and that type of behavioral problems, these actually, in my experience and others, can be very well controlled with some of the newer so-called atypical antipsychotics. A bit of a digression. Again, when I was a resident, in the beginning of my residency, we didn't really have, or at least most of these medicines were not available. And so when patients with Parkinsonism developed severe behavioral problems or psychosis, we really had a quandary because the medicines used to really help alleviate those behavioral and psychotic features virtually all made the Parkinsonism worse. But beginning, I guess, in the early to mid-90s, with the introduction of some of these agents, we really have turned the corner. I've listed several of them there that I find particularly helpful. I have to say that the one actually that I go to first, and I'll be interested in Dr. Stewart's take on it, but I really use quetiapine or Seroquel first. I've had, this medicine came out in the late 1990s, and I've used it in literally hundreds of patients, and I have just been very, very pleased with the fact that I've never seen it exacerbate Parkinsonism, and using it in low doses